We're at the 25th CROI. We're here with Carl Dieffenbach, who's Director of Division of AIDS at NIAID. And we appreciate him taking the time to break away from a very busy conference. Not a lot of craziness, but except for the weather. But we do have a lot of little pieces that are happening at this conference that are, I would say, pretty important.
There's some outstanding science at this meeting. It's really great, Fred.
So I guess we always want to talk about what impact things that are happening at the NIH and NIAID that are important from the governmental standpoint. And I think the biggest thing is budget, but I know that we don't generally talk about that, but always funding of all the things. I talked with one young lady who's working with a database down in South Africa that's being funded by the NIH, which is really important to have this background knowledge of what's happening, and combining it with HIV/AIDS. So it's all kind of interrelated and very helpful for her to move along. But tell us about what you know that's important from your perspective.
So let's just spend a brief moment on the budget. The budget is actually looking reasonably good. We are still under a continuing resolution for the rest of a big part of March, and then we'll see. It's not going to be the president's budget, but it'll be somewhere between the House and Senate mark, so stay tuned for that. In terms of the science that has been presented at this meeting, there continues to be advances in our understanding of how to use antiretrovirals, how to improve the delivery of antiretrovirals, and how to improve the care continuum. So it continues. There's just this march of steady progress that we continue to see that has a profound impact for both treatment and prevention. It's quite good.
The drugs are always more. The bar has risen so high that you almost have to look at how to use them differently today because they are so good, and so useful, so safe, and
safety has been safety and tolerability have been improved. The drugs are definitely safer than they were back in 1996 when we started in this in the HAART era, and it's wonderful to see where we are. I think the interesting thing that we are going through is hopefully another wave of innovation with long-acting. So can we get to a point where instead of one pill once a day, you have an implant that lasts a year, or you have an interim technology right now is we're testing with cabotegravir is 8 to 12 weeks of an injectable. That in and of itself is remarkable. So with therapy, can we also achieve that level of coverage and then sustain virologic suppression with an implant or with other delivery methods? You know, the big question, so this is where we have the intersection of behavioral and social science with the biomedical, is so are there people that would want and effectively use a pill a week or a pill a month? Or does that create some sort of gap with remembering in a routine that is harder? It's a higher activation energy than a pill a day. So there's a lot of psychology that needs to be worked into this as we go on. But these are the problems you like to have.
It seems like a lot of people would feel who have this concern about people seeing that they're taking pills every day. And if you don't have to do that, if you have to go somewhere and have an injection given, that it would be all right. And maybe then it's just a matter of a phone call. We have text messages today, and in deploying that technology, everybody, no matter who you are, you seem to have a cell phone. So that would be a helpful thing. But getting the delivery of it is really psychologically an issue.
I think it is, and I think there's a lot to be worked out there. There was a report here that financial incentives didn't seem to make a difference. So that's an important thing to understand. As we go through the different tools for behavioral intervention, what will work and what will not, to improve adherence, to get us to a point where the continuum of care is as close to 90-90-90 as possible.
I talked to a number of young researchers and people that are interested in the psychological issues. There seems to be a concern that certain people in low-income populations, maybe even homeless, or who are not really connected with, who are living with a challenging life, And how do we get those people into prevention, such as PrEP? Because those are the vulnerable populations. Do you have anything that's happening in education, any funding for education?
So it's interesting. So Bob Remian, who is one of the leading lights in behavioral and social science research in New York City, talked today about the importance of mental health in HIV and people who have mental health in a range of diseases. This then exhibits as different behaviors and different outcomes have significant challenges staying in care and being linked into care. And he made the point that addressing the mental health burden in the United States, and particularly in HIV-infected and at-risk people, would go a long way toward helping to improve the delivery of PrEP, the delivery of antivirals for treatment. So you have people that are homeless. That comes with food insecurity, with housing insecurity, and we know from studies that for both food insecurity and housing insecurity issues, people engage in risky behaviors in order to get the resources. They trade sex for food. It's not just in the United States, it's around the globe. This is a universal behavior. So the mental health aspect that Bob shined a light on today is a very important part of what we need to do collectively as the leadership, looking at all the challenges that HIV presents across the United States and the globe.
Once we've identified them, then we need to list them and say, okay, hammer these home because these are really important. We've identified them. Now let's deal with it.
Yeah, and as we know, there's a mental health crisis in the United States. There aren't the providers that are needed and resources for mental health treatment. I mean, think about the opioid crisis.
Yeah.
This is another big issue. Is the ability to receive substance use. Substance use disorder is a classified psychiatric syndrome. Care for that is abysmal right now. That people don't have access. Insurance doesn't tend to cover it. So we have a problem domestically with making sure that we can get people the treatment that they need, whether it's a pill or it's for psychological syndromes, such as substance abuse disorder.
And educating them as far as the reasons why. I don't think certain populations are looking at it as being well enough educated about the issues that they're facing, and their lifestyles kind of are not their perspective of their life is so much more important than this little pill that they have to take, and they don't realize the importance of that little pill in the grand scheme.
I think it comes down to what you're saying is it's what's important in your life. If you have a chaotic life and you cannot then manage taking a pill a day, I think that's a reality that it's the way that some people are. So how do you help them to understand or help them manage the chaos under which they're living? And often that is also a form of a psychological disorder.
So we have this issue with gun control measures that are up, and this is the interest now is trying to get to mental health, and now we're looking at it from another perspective. So maybe we really are seeing that we have to address the mental health for many reasons in this country, and finding a way to do that is not going to be easy.
Yeah.
It's not going to be affordable either. I don't know.
Well, part of the
has to
issue is if it's important, we'll find a way. We have to, as a society.
Right. Well, anything else you want to cover?
So I think at this meeting there continue to be some very interesting breakthroughs in other areas like tuberculosis. We have a study being presented here at the meeting where for people who have evidence of early TB infection or live in areas of the world that have very high endemicity of tuberculosis, that the usual drug regimen to treat somebody or to help them prevent their TB is 9 months of INH. We did a study comparing 9 months versus 1 month of rifapentine, and they were equivalent. So which would you rather take, 9 months of a drug that really has significant side effects, or 1 month of rifapentine? This has potential to be a major game changer across the globe in terms of really having an impact on tuberculosis. So we want to keep our eyes on that. It's not so much a problem in the United States, but globally, if we don't solve the TB epidemic while we're solving the HIV epidemic, we ultimately will fail.
I think that early days we looked at HIV, we were wanting people to be treated globally HIV, and then they said in South Africa, this is malaria and TB is first, and so it seems that, that's their interest.
Right, and South Africa as a country has done a phenomenal job picking up their HIV care and really moving forward in a significant way. But TB remains important for all the countries in sub-Saharan Africa.
Great. Like I said, you can go to any session and see something that, that I thought, oh, what about that? And we revisit things sometimes, like we're doing with bringing that treatment down. And because if people take a monthly dose home with them, they may have resolved their TB. And that would be rather than having to go back and keep on going back if they can't afford the time or the whatever to go back. So it's a great opportunity. Well, I appreciate very much your taking the time with us.
It's always a pleasure, Fred.
And it's always we have more hope. And of course, the cure is still being worked on very hard, which we appreciate the energy from the NIH as well and NIAID as well. So it's great. Thank you very much.